Madam, we are live now. Shall we start?
Yeah.
So good evening, doctor. I welcome all the doctors in Shield Connect for this medical session with Dr. Anju Sharma, madam, on hot flashes during menopause. And it's my honor to introduce Madam. Madam Dr. MBBS, MS Obstetrics and Gynecology. Madam is a senior consultant in Lotus Super Specialty Hospital, Agra. So in this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation, and please put your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you. Thank you very much, Madam, for your valuable time in Shield Connect, and over to you for further proceedings. Thank you very much.
Thank you. Should I start?
Yes, ma'am.
Good evening, doctors, and good evening, dear friends. Today, I am going to speak about hot flashes during menopause. It is a demand of the time to address, so I chooses this topic to address hot flashes. So before discussing the hot flashes, I will tell you a little about the menopause. Sorry, I can't move the slides.
Madam, you please press the lower arrow button in your keypad, ma'am.
Pardon?
You can use down arrow key.
Okay. Is it visible now?
Yes, ma'am. Make it full slide soon, ma'am. Full screen.
Okay. Okay. Now it is visible. Yeah. So menopause is a normal natural event in a woman's life, and it is defined as the final menstrual period, and it is confirmed after the 1 year of no menstrual bleeding.
It is, sorry for the interruption, it is not in full screen, I guess. So can you please click on the slideshow button in the upper panel? Slideshow button.
Okay, I'll try.
In just upper toolbar.
Okay.
Insert draw, design, transition. There we will find slideshow.
Yes.
Yes.
Now it is okay?
Yes, it is okay.
Yes.
Coming fine, ma'am. Thank you.
Yeah. So menopause is a retrospective diagnosis. Once the lady stops menstruating for 1 year, then we defined her as she has passed in the menopause. So it represents the permanent cessation of menses and resulting from loss of ovarian function due to aging. So when the menopause occurs in Western countries, the average age is 51, while in India, average age is 47 years. And sometimes premature menopause occurs if the lady has undergone bilateral oophorectomy or hysterectomy, or she is on chemotherapy, so ovaries are knocked off. And any time where there is a declining ovarian function or follicle numbers reduces less than 1,000, that leads to menopause. If we see in the Indian scenario, there are approximately 60 million women above the age of 55 years. And the life expectancy in India is around 65 years, while in Western developed countries, it is more than 80 years. So a woman passes her 1/3 life as postmenopausal. So it is very important to relate menopausal diseases, menopausal problems, and prophylaxis. Age of menopause is directly related to the genetic predisposition and smoking. It is not related to race, menarche, pregnancy, or use of oral contraceptives. And smoking is very, very important because it leads to premature menopause. Lots of women now use of smoking. So if we go the reproductive staging, it is by straw. in this reproductive period, menopausal transition and postmenopausal period. So we all know the one thing is very important, the perimenopausal or climactic. This is the area 1 to 2 years before the menses or 1 to 2 years after the menopause. So these 4 to 5 years are very important. All the variations are occurring in this period. So the today's topic, that is hot flashes. So this is also very important problem of this perimenopausal time. Again, if we see the quality of life, and again the postmenopausal women's having symptoms, and their quality of life is also very much affected, moderate to mild degree. Prevalence of symptom was 47% in India. And this slide is also very important, as the age of menopause is fixed, but life expectancy has increased. So so one lady passes most 1/3 of her life as menopausal. If we see the hormonal variations, circulating levels of estrogens decreases during menopause, and the ratio of estrogen to androgen also goes down, and sex hormone binding globulins also decreases, and there is increased peripheral aromatization of DHEA to estrone. Most of the estrogen that is produced after menopause is from adrenal glands, not from ovaries. And reversal of E2 to E1 ratio is there. Previously, in the reproductive age, it is around 2:1, and during menopause, it reduces to 1:2. And there is no significant changes in the testosterone levels. If we see this slide, this is also very important. As the estrogen is declining, the first and foremost symptom is the vasomotor symptoms. That is the hot flashes. Around the perimenopausal area, around that is means 45 to 51 or 52, we have hot flashes, mood swings, sleep, insomnia, and acute cognitive changes. And urogenital symptoms appears a little bit later, 2 to 3 years later. And because of declining estrogen, cardiovascular symptoms appear again another 5 years later. And osteoporosis sets up in the age of 60s. While cognitive changes or Alzheimer's, it occurs after the age of 65. So we have a pretty good amount of time, 2, 3, 4 years, in that we can treat the lady and impose her on lifestyle changes and all the medicines. So all these changes can be delayed. Little bit about the physiologies. Each ovary has certain number of oocyte from the birth, and these number of oocyte steadily decrease as the V reaches to menopause. So stock of follicles becomes exhausted. So in the perimenopause, follicular activity fails and estrogen levels declines, and pituitary gland produces much more amount of FSH and LH as the negative feedback. Cycles become anovulatory and the follicular development stops. Endometrium is no longer stimulated and amenorrhea occurs. It is the physiology, as we all know. So the core symptoms of menopause is the vasomotor symptoms, that is the hot flashes, vaginal symptoms, dryness and dyspareunia, and insomnia and mood changes. Coming to the hot flashes, as much as 85% of postmenopausal women suffers from hot flashes, and around 55% women suffers hot flashes before the menopause, that is in the transition phase, climactic or perimenopause phase. The exact cause of or etiology of hot flashes is not very certain, and most theories support that there is a declining level of estrogen. But if we study the level of estradiol during hot flush, it is not changed. So the hot flashes is somewhat related to the FSH and fluctuating level of estradiol. And it is because of resetting and narrowing of the thermoregulatory system in association with the fluctuation or loss of estrogen production. So it is very important. It is not the low level of estrogen. It is the fluctuating level of estrogen and FSH. That is the cause of hot flashes. If we see the duration, so approximately 5.2 years, a lady suffers hot flashes, around 5 years. After that, it goes by itself. So if we studies meta-analysis, so our first year of menopause is we have very intense hot flashes. After that, suddenly, slightly intensity and duration of hot flashes keeps on declining. So what does decreased estrogen do? Decreased estrogen level may reduce the serotonin level and thus upregulate the 5-HT receptors in the hypothalamus. These 5-HT receptors secrete more serotonin, and that causes the changes in the set point temperature, and that leads to hot flashes. So we see the pathophysiology of hot flashes. The core body temperature increases, a blood flow to the skin, and the heart rate increases. So there's an intense feeling of heat and reddening in the upper body. Heart rate peaks and skin blood flow peaks. And there's a sudden severe sweating. This sweating leads to the decrease in the core body temperature. Again, to restore the temperature, there is shivering and chills. So this is the whole cycle of a hot flash. It takes 2 to 4 minutes. So sudden sensation of heat on the face and upper chest, that becomes rapidly generalized. The sensation lasts for 2 to 4 minutes, and it is associated with profuse perspiration and palpitation, and followed by chills. And it is very बहुत ही डिफिकल्ट पार्ट होता है लेडी का कि आप सर्दी में भी बैठे हुए हैं तो भी आपको सिवियर स्वेटिंग और चिल्स आ रहा है, and this is a typical hot flash. So this is because of changes in the thermoregulatory system. Inappropriate peripheral vasodilatation, increased distal and cutaneous blood flow, and rapid heat loss so leads to decreased core body temperature below normal. To restore this core body temperature, there is shivering. This is the mechanism. If we see the intensity and duration and frequency of the hot flashes, so during perimenopausal perimenopausal period, around 40 to 45, there can be high frequency and high intensity, usually several times a day, that is per one or maybe 1 to 2 times per day, or it may be so high as one hot flush every hour in day or night, disturbing the sleep and in very irritating to ladies. As the age advances, hot flashes slightly keeps on decreasing, and after the age of 60, most of the time ladies are free from hot flashes. So if we see the prevalence, then before perimenopause, around 14 to 51%. During the perimenopause, 50% of the women suffers from hot flashes, and after menopause, 30 to 80%. Generally, it is believed that hot flashes do not occur in premenopausal women, but some women, even during menstrual period, may suffer from hot flash. However, large observational study, SWAN study, found 20% of premenopausal women report hot flashes. So if we see the etiology of hot flash, pathophysiology of hot flashes, there is a dysfunction in central thermoregulatory center in the hypothalamus. Estrogen is very important. Withdrawal, it is the withdrawal or rapid fluctuation level rather than the low concentration. To certain this theory, if we see the cases of Turner syndrome, these ladies have they lack the normal amount of estrogen, but they do not experience hot flashes. Once we treat them and give them estrogen and then withdraw estrogen, then they suffer hot flashes. So low level of estrogen is not responsible for hot flashes. Rather than fluctuating level of estrogen are very important. So another thing is changes in neurotransmitter levels like norepinephrine and serotonin. Risk factor is again obesity, smoking, less physical activity in socio-demographic studies. And now how to assess the severity of hot flashes? It is very subjective. Some lady will be very much bothersome with few episodes, and some will tolerate well. So to calculate the score, severity of the score, there's a method: number of mild hot flashes per day into 1 plus number of moderate to 2 plus number of severe hot flashes per day into 3, or of very severe hot flashes into 4, divide number of hot flashes per day. So the interpretation is very subjective to patients. The scoring is very important to treat the patient. If the patient is, how will assess how much patient is getting relief. Another is Greeny climateric score. It is again a more detailed. It takes so many symptoms, 4 subcomponents of both symptoms and quality of life. Severe, more the score, more is the severity. And third is the modified Copperman score. It again assesses the 11 subcomponent: hot flashes, sweating, insomnia, nervousness, depression, vertigo, tiredness, joint ache, headache, palpitation, vaginal dryness, and all are scored from 0 to 3. So higher the score, worse is the symptom. Now going to the treatment. The treatment of hot flashes is hormonal and non-hormonal. In hormone, we have estrogen, tibolone, and bioidentical hormones. In non-hormonal, we have CNS agent, as I already told you. Serotonin and norepinephrine has a role in etiology of hot flashes. So selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors are the drug used in this, and gabapentin is also can be used. Complementary and alternative medicine, though not FDA approved, but have some role in mild hot flashes like acupuncture, phytoestrogen, phytoprogestin, and lifestyle changes. So estrogen is the most important hormone, and it is FDA approved only drug to treat the hot flashes. Moderate to severe hot flashes may will give for 2 to 3 years, but not more than 5 years. The goal of therapy is to give minimum amount for minimum period of time. Long-term use is no longer indicated. In mild hot flashes, do not require any hormone therapy. Effectiveness of estrogen is highly effective to treat vasomotor symptoms. It stops hot flashes in around 80% of women and reduces the frequency and severity in the remainder. And this is the only therapy currently approved by FDA, as I already told you. So as we all know, the route of giving estrogen is, we have a large choice. We can give it orally, parenteral, topical, vaginal, or transdermal. They all have similar effects, but we have to tailor-made the drug, giving the drug according to women to women. We have to tailor-made the doses and the route of administration. Though the oral route is most popular, but transdermal is much more safer because it avoids the liver's first pass effect, and it is very convenient. Only 1 to 2 a week you have to stick a patch. So how to give the therapy? If the lady has undergone hysterectomy, there is no harm. We can give continuous estrogen. No progesterone is required, no tablet break, and there will be no bleeding as the uterus is not there. But the lady with the intact uterus, we can give continuous sequential HRT, means throughout the cycle we'll give estrogen and progesterone in the last 14 days and without a break. And if the lady without a break, and there will be regular bleeding at the end of the cycle. So this type of the therapy should be given in a perimenopausal women that are menstruating frequently or infrequently. But in a postmenopausal women who is already established menopause, in that case we have to give we should give combined estrogen and progesterone without any tablet break, so there is no bleeding at the end of the cycle. Estrogen is sometimes contraindicated. We have to give a thorough history. We have to take a thorough history of the women. If there is any undiagnosed genital bleeding, estrogen should not be given. And if there is suspected or history of breast cancer or estrogen-dependent neoplasia. In cases of active DVT, pulmonary embolism, or history of these conditions, estrogens should not be given. Liver dysfunction or hypersensitivity to estrogen preparations and pregnancy, we all know, we cannot give estrogen. And when to give the, when to start hormone therapy, timing, sooner is the better. We should not wait to 55 year or 60 year. In the perimenopausal lady, we should start the estrogens. Maintain the beneficial action of estrogen. Personalization is, again, as I already told you, tailor the type, dose, and route according to the choice of the women. No one preparation suited to all women, we all know. Select the right dose for the right women. Balance the benefit versus risk. And we try to stop the therapy in 2 to 3 years or as early as possible. Counsel the women, no long-term estrogen should be given. Progesterone alone, somewhat in the women in where the estrogen is contraindicated, we can give progestins, and they inhibit the GnRH secretions and can treat hot flashes. And combined with the estrogen, progesterone prevent endometrial hyperplasia. And this is a study, PEPI trial, in which we study the estrogen alone and estrogen plus progesterone sequential and estrogen plus progesterone continuous, the effect on endometrium by endometrial biopsy. So whenever when we are adding estrogen with progesterone, the chances of endometrial hyperplasia, complex hyperplasia, and cancers are markedly reduced. So in a lady with intact uterus, we should not give alone estrogen. Estrogen should be combined with progesterone in the sequential or continuous form. Tibolone, again, it is synthetic steroid. It has a weak estrogenic, progesteronic, and androgenic property. It has anti-estrogen on endometrium and on vagina. 2.5 milligram per day. It is widely used and reduces vasomotor symptoms and beneficial effect on BMD. We can leave this. This is not very important. Again, non-hormonal CNS agents, we have selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors and gabapentin. And complementary medicines, as I already told you, these are not FDA approved, but acupuncture, phytoestrogen, phytoprogesterone, and lifestyle changes. So in a case of mild hot flashes, do not give pharmacological estrogen therapy and try to give them lifestyle changes and some other things, non-prescription therapies. So lifestyle changes, we have to give them advice regarding keeping the core body temperature cool and regular exercises. Soya foods, isoflavone supplements, and black cohosh, red clover, and vitamin E. These are also somewhat effective. So as I have already told you, non-hormonal treatment is not FDA approved. Long-term studies are not available. Short-term trials are available. If the woman cannot take estrogen or she is not willing to take hormone therapy, in these cases, we can give them these drugs. Central nervous system drugs, we have selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors. These are very effective drugs for hot flashes like venlafaxine, fluoxetine, and paroxetine. And SNRI, we have desvenlafaxine. Modest improvement is seen in the hot flashes, and these are the various drug and their doses. And when estrogen is not is contraindicated, and that in that cases we can try this. So these drugs have some side effects like nausea, diarrhea, headache. So we have to counsel the lady. And lady receiving tamoxifen for breast cancer, these drugs should not be given. The effect of tamoxifen will be decreased. But these drugs are very important for the women who are suffering from hot flashes and they are on the treatment of breast cancer and receiving letrozole. In that case, we can give fluoxetine and venlafaxine. This is the rather indication of giving these drugs. So this is the data, how much effect is there on hot flashes. So these drugs are not so effective as estrogen, but they are significantly better than placebos. Complementary medicines, the use is now increasing. It is very much in fashion. Soya foods and isoflavonoid, black cohosh, black tea, exercises. So many yogas are there. Yoga classes are there. Safety and efficacy is no problem. Soya and black cohosh is no more effective than placebo. Lifestyle changes are very important. We can tell the lady to dress in layers. During the time of episode of hot flash, she can remove her sweater and 1 or 2 layer of clothes and keep the water near, and she must on the fan. And quitting this smoking is very important, as smoking causes premature menopause. Reduce the hot drinks like caffeine, alcohol, and try to maintain healthy weight. And meditation and yoga has also had much role. Deep breathing exercises is very important. Healthy lifestyle, engaging yourself in different activities also reduces the hot flashes. So it is now we are coming to the treatment of intractable hot flashes. So intractable hot flashes is a very difficult to treat, rather a tricky situation. In this, even after giving the maximum amount of estrogen, the lady is not relieved of her symptom. So in that hot flashes, maybe we are understanding that she may be suffering from so many carcinomas, carcinoma producing lot of norepinephrine. And in a situation like hyperthyroidism, you have these situations. And certain drugs, alcohol plus chlorpromazine, alcohol, and amyl nitrate, nicotine, levodopa, bromocriptine, these all lead to hot flashes. And we are treating only the menopausal part. So we have to consider these diagnoses. And if the lady is on drugs that decreases the absorption of estrogen, to remove that drugs like broad spectrum antibiotics, barbiturate, anticonvulsant, and triclosan, these are enzyme inducers. So the level of estrogen we are giving is not getting, lady is not getting that much. So we have to stop these drugs or increase the amount of estrogen. Changing the route of administration, change from oral to transdermal, and increase the size of patch. There is no clinical data, but these things help. Finally, if the lady is not getting affected, it not getting relieved, we can stop the estrogen for 1 to 2 weeks and restart at the usual dose. So the women will suffer from more hot flashes at the withdrawal of estrogen. Sorry, that time the hot flashes not completely disappear, but she will learn that this much amount of estrogen is my hot flashes, and I am better with the residual hot flashes. You got my point? आप एक बार उसकी सारी ड्रग बंद कर दीजिए लेडी की, जो भी एस्ट्रोजन वो ले रही है, तो उसको एक सीवियर अटैक ऑफ हॉट फ्लैश आएगा, फिर आप उसको वही ड्रग दोबारा से दीजिए, तब उसको समझ में आएगा कि हाँ ये ड्रग इफेक्टिव थी, मेरी क्वालिटी ऑफ लाइफ काफी बेटर थी. So this is also a treatment of intractable hot flash. These are the various combinations of drugs and available drugs. Premarin is also very effective in treating the hot flashes. So one thing is there that we will give a usual dose like 0.625 of Premarin, but we can reduce it up to 0.3. A very low dose should be given of, we should try lowest possible hormone therapy. These are the non-hormonal therapy, gabapentin, fluoxetine, and venlafaxine, paraglabin. Now to concluding my talk, HRT is the mainstay of the treatment of vasomotor symptoms. In cases of moderate to severe hot flashes, we should give HRT. Don't be afraid of giving hormone. Previously, in 2002 or 90s, the hormone therapies were badly bad propaganda. It will cause cancer, but not it is not so. A minimum amount for minimum period of time can be freely given. So to improve the quality of life, if she is having so much hot flashes, don't be afraid of giving estrogen. Give her estrogen. And OC pill will not do. The ethinyl estradiol is a synthetic estrogen. It will not help in treating the hot flashes. We have to give the natural estrogen, that is equine primarin or estradiol. Moderate to severe vasomotor symptoms, short-term therapy is the treatment of choice, 2 to 3 years, but not more than 5 years. Use lowest effective dose, start earlier in the menopause, and gradually taper in 1 to 2 years. If estrogen is contraindicated or not tolerated, use gabapentin or these SNRI or SSRI, as I've already told you. The women with breast cancer having hot flashes, we should not give them phytoestrogen or black cohosh also. These women's fluoxetine is the drug of choice. Women with predominantly nighttime symptoms, single bedtime dose of gabapentin is very important, because gabapentin causes sedation. So we give them to the nighttime. If the women with predominantly daytime symptom, then we should give fluoxetine or rather than giving them gabapentin. Thank you. And this is a new drug, Estrogen. It contains cinnamic acid, methyl ester, and dicursin. And studies are conducted on this drug, and it is found to be very effective in preventing vaginal dryness, hot flashes, mood swings, and bone pain. So estrogen is not a estrogen hormone, but it is found to be very effective. Thank you. Thank you, friends, for patiently.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time to check if any question in the dashboard.
Okay.
One question is, as hormonal and non-hormonal therapies are available for treating this problem, but what is the first line of treatment when a patient approach with these hot flashes? So what would be the preferential medications for treating this problem?
Okay. Once the patient comes with the hot flashes, we have to find out about the frequency and duration of hot flash. If it is severe to moderate, we can go for hormonal therapy. And if it is mild, then we can counsel her and give her lifestyle advices, and she can cope well with that. And some complementary medicine can also be given as a placebo or somewhat we have given to her.
Thank you very much, ma'am.
Yeah.
And I got another appreciation from Dr. Seema madam. She told that super presentation. And also madam asked one question, that if hot flashes are a longer period of time, means for a longer duration, and if it involves sleep disorder too, please suggest how to deal with this.
Again, for sleep disorders and hot flashes, we have to first treat the hot flashes, and all the therapy we have to counsel her. And again, in these cases, this Kupferman is scoring, and all these scorings are very important. Make her write down her severity once, and then give her treatment, and then again reassess how much effect she has gotten from the treatment. Simply saying ki ha madam aram ho gaya ya nahi hua, then she will not be affected. And deep breathing exercises, yoga, and lifestyle, weight reduction, lot of caffeine and smoking should be cut, alcohol should be cut. So these are the therapies along with estrogen we can prescribe her. And sometimes we have to take the help of psychiatrist also. If there's mood swings are very much, it may not be because of menopause. So something is there that is very intractable. Do not ascertain it is postmenopausal. We have to find out other causes rather than menopause.
Okay. Yeah, thank you very much, ma'am. So, ma'am, I could not find any other question right now.
Thank you
so much. If you allow me, then we can conclude this session.
Thank you so much.
Thank you. Thank you very much, ma'am, for your valuable time once again, for your time in our platform. And in future also, I look forward for some valuable session with you, ma'am.
Thank you so much. Nice.
Thank you. Thank you, ma'am. Have a good day.
Thank you, Tulika, for helping me a lot. Thank you.
Thank you, ma'am.